What if I told you that one of the biggest causes of stroke isn't actually in the brain at all? Nope, it's hiding in your neck. Today, we are going to dive deep into a major cause of ischemic stroke, the super risky procedures used to fix it, and the incredibly tough decisions that doctors and patients have to make every single day.
And get this, about 10% of all strokes can be traced back to this one single problem, a blockage in the main arteries that feed your brain with blood. Think about that. A single point of failure that can have absolutely devastating consequences. And this is what we're talking about. It's called carotid artery stenosis. Just looking at this image, you can see how that artery is dangerously narrowed. It's basically a massive traffic jam on the superhighway of blood flow to your brain. And honestly, it's a stroke just waiting to happen.
So, let's break this down. What exactly is this condition and how does it even start? To really get a handle on the risk, we first have to understand the cause. The main culprit here is something called atherosclerosis. The easiest way to think about it is this. Imagine your arteries are brand new, clean pipes. Well, over time, these fatty deposits, this plaque, starts building up on the inside walls. This gunk hardens, it narrows the pipes, and that restricts blood flow. It also creates this rough surface where really dangerous blood clots can form. And who's at risk? Well, the risk factors are probably pretty much what you'd expect. Getting older, being male, smoking, and of course having high cholesterol or high blood pressure, they all contribute to this nasty plaque buildup. It's a really quiet process that can go completely unnoticed for years. Okay, so if it's so silent, how in the world do you find it? Before anyone can even think about a treatment plan, doctors need to get a perfectly clear picture of exactly what's going on inside that artery.
And lucky for us, they have an amazing diagnostic toolkit to do just that. These incredible imaging technologies let them basically peer inside the artery, see the plaque, measure just how bad the blockage is, and figure out the real risk of a future stroke.
A lot of the time, the very first step is a simple, totally non-invasive ultrasound. It's a quick and safe way for doctors to screen for plaque and just see how well the blood is flowing through that carotid artery.
Now, if they need a more detailed look, they might turn to magnetic resonance angiography, or MRA. This technique creates this beautiful high-contrast map of the arteries, showing their structure in amazing detail. And this is a huge plus, it does it all without any radiation.
But the undisputed gold standard is something called digital subtraction angiography, or DSA. And this is just incredible. They take an X-ray before and then another one after injecting a contrast dye. Then, a computer digitally subtracts that first image from the second, and what's left is this perfectly clear, unobstructed view of just the blood vessel and the blockage. So cool. So, once that blockage is confirmed and measured, the patient and their doctor arrive at this major crossroads. I mean, a huge decision. Do you manage this with the best medicine out there, or do you choose an invasive and pretty risky surgical fix? You know, for a lot of patients, especially the ones who don't have any symptoms, medical therapy is absolutely the way to go. We're talking about lifestyle changes, sure, but also incredibly powerful drugs like statins to get cholesterol down and antihypertensives to control blood pressure. And the results? They're just staggering. With the right medical treatment, the annual risk of having a stroke can be pushed way down to less than 1%. Some studies have even seen it as low as 0.35%. That just shows you how far modern medicine has come. But that, of course, leads to the big question. What happens when medicine just isn't enough? For patients who've already had a warning sign, like a mini-stroke, or whose arteries are just severely blocked, well, the conversation has to shift toward a more direct intervention. And this is where we get to surgery's double-edged sword. These procedures can absolutely prevent a catastrophic stroke down the road, but they come with their own set of immediate, potentially life-threatening risks. So you've basically got two main options. The first is carotid endarterectomy, or CEA. This is an open surgery. The surgeon makes a cut in your neck, opens up the artery, and literally scrapes the plaque out. The other option is carotid artery stenting, or CAS. This one's less invasive. They thread a tiny tube with a stent on it all the way up to the blockage, and then expand it to prop the artery open from the inside. Now, here's the crazy irony of these procedures. The very thing they are designed to prevent, a stroke, is actually one of their biggest risks. I mean, this quote from the source material is just chilling. The surgery itself can knock a piece of plaque loose, and that can cause a stroke right there on the operating table. But the danger doesn't stop at the brain. When you operate on these critical arteries, you're putting an immense amount of stress on the entire cardiovascular system, and that introduces another major life-threatening risk.
And that risk is a myocardial infarction, a heart attack. This is so serious, in fact, that it's a key safety measure that researchers track in every single major clinical trial, like the famous CREST study. It's one of the primary endpoints they look at to decide if a surgery is truly safe and effective.
So here's the bottom line. Within just 30 days of having either of these carotid surgeries, somewhere between 0 and 2% of patients will suffer a heart attack. Now, that might sound like a small percentage, but when the consequence is a potentially fatal heart attack, any risk is a huge deal. And here's a really crucial distinction between the two procedures. The data from those big trials shows that the risk of a heart attack is actually a little bit higher with the more invasive open surgery, the CEA, when you compare it to the stenting procedure.
So you have to put it all together, right? The long-term risk of a stroke from the blockage itself, the amazing power of modern medicine to prevent it, and then the immediate dangers of the surgery, including not just stroke, but a heart attack. It all leads to this incredibly complex and difficult balancing act. This table really puts the entire dilemma into sharp focus. Look at the top line. With drugs, your risk of a stroke in any given year is tiny, less than 0.5%. But if you choose surgery, you're taking on an upfront risk, and that results in a cumulative stroke risk over 10 years of more than 5 or 6%. And remember, that doesn't even factor in the other immediate complications we talked about, like having a heart attack during or right after the procedure.
And that leaves us with this final, really provocative thought to chew on. As our medications get better and better at managing this disease, at keeping that annual stroke risk near zero, does that fixed upfront risk of a major surgical complication, a stroke on the table, a heart attack, make the choice to operate harder and harder to justify? It's a question that gets right to the very heart of modern medicine.